We divide the human skeletal system into an axial skeleton, which composes the bones which lie along the longitudinal axis of the body, the skull, the vertebral column, and the thorax. And then the appendicular skeleton, this would be the bones of the arm and leg. And then the two girdles which attach the bones of the arm and leg to the axial skeleton. This would be the pectoral girdle for the shoulder and the pelvic girdle at the hip. This video is going to be about the pectoral girdle and arm. There are two bones in the pectoral girdle, the clavicle or collarbone and the scapula. The clavicle articulates both with the sternum at the manubrium here, and then at the acromion of the scapula, and I'll define that term presently. Now, when my students, need to identify structures, I often joke that there's, one thing that they can do to help them out in lab exams to identify structures is that they can cheat. All right, in that you come to class with a skeleton, with bones arranged in anatomically correct position. You can use these bones within reason to help you get some of the right answers. So for example, if you were required to know, say, the difference between, say, the acromial end and the sternal end of the clavicle, and you don't know, and there's a clavicle in front of you, and you have to identify it, what do? You cheat. You touch your own clavicle, because you can realize, all right, so here's my clavicle. Ooh, this end here at the sternum, this feels kind of like a bigger knob. And then as I follow it here to where it meets the scapula, here it's rather flat. Oh, so this flat end, this must be the portion which touches the acromion of the scapula. This knobby end must be the end that contacts the sternum. This must be the sternal end. I can feel that. And so then going forward, I'm going to emphasize that because, a student in the middle of an exam, you can, feel anxiety, you can feel panicked. I studied this, I'm forgetting. You can just calm down and then touch the bones that you have the sense to bring to class with you. And very often you can use them to help you get the correct answer. So I'm sorry, pause that because it'll slow down. So now let's go to the, now let's go to the scapula, which is the second bone in the human pectoral girdle. Now, the first thing that you have to do with a lot of these bones, and the scapula would be one, is you kind of have to find out how it is oriented in the body. You have to know whether you're looking at the left or the right scapula. Otherwise, you just don't have the frame of reference to make the correct identification of regions. So our first question is, how does this sit in the body? So to identify a bone as being left or right, there are three things you have to know. You have to know which end faces, say, up or down, superiorly and inferiorly, which is front and back, which is the anterior side, which is at the posterior side, and then which faces medially towards the midline or laterally away from the midline. So if you look at a scapula, what do you do? Well, the first thing is that you'd realize, well, obviously, there's going to be a socket. The shoulder joint is one of the two ball and socket joints in the body. So obviously I have a socket. Obviously it has to face this way. If your shoulder was facing this way, then your arm would be coming out of the middle of your back, and you would have noticed that when you got dressed this morning. And so this obviously has to face laterally this space, which we'll define as the glenoid cavity. We know that the spine of the scapula, this bony ridge, faces posteriorly. The reason we know that is we can feel it. So one of the sides of the scapula has this bony spine, and the other side doesn't. And if you're wondering, which side faces forward, which side faces posteriorly, anterior versus posteriorly, you can feel the spine on the scapula. So then obviously that's the side that faces posteriorly. And then finally, which faces up or which is down. Well, here we can see this big triangular part of the bone here. And if that was facing up, I would feel that. It would be here, all right? And so, and that I can just by examining my own scapula, I know that this faces laterally, that the spine faces posteriorly, and that this angle here must be inferior, or else I would feel this big triangle of bone here. So knowing these three things, I can distinguish then between the left and the right scapula. And once again, before I do that, then I really shouldn't start naming other structures because I just don't know enough yet. Once I am comfortable then with that, I can see that the scapula looks to be like a triangle. And as a triangle, in addition to this inferior angle, which is pointing down, there would then be the superior angle, which is obviously then superior. And as I'll continue in the next video, we can now look at the borders here, because once I know how this sits in the body, one of the borders is facing medially towards the vertebral column. And so this obviously could be named the medial or vertebral border. And then the other border is facing laterally towards the armpit or axilla. So that could be referred to as the lateral or axillary border of the scapula. The spine is a very prominent area. And we're going to not only refer to the spine, but then also to then depressions on either side of the spine using the term fossa for depression. Now, one of the reasons we're focusing on this is because later we want to study the muscles. And muscles, instead of attaching to flat surfaces, if they can attach to ridges or edges or etc., that very often is a better site to grab and to pull a bone from. And so not only are we interested in the bony landmarks here, but many of these will be the origins and insertions of muscles, which we study later. So they will certainly be important. So the shoulder joint is one of the body's two ball and socket joints, as we will see. And so then we will focus on the glenoid cavity, where the round head of the humerus is spinning, but then also the acromion, which is the end of the spine. And then once again, getting back to the clavicle, once again, you can cheat. One end is the sternal end, and you can feel this knob at the sternum. The other end obviously must be the acromial end, because then you can feel that flat surface, then contact the acromion, which is continuous with the spine that you can feel. So here is the spine of the scapula. Once again, important for muscle attachments. The trapezius is ending in this region, attaching here. The deltoid is beginning in this region. And there are depressions on either side of the spine. Above the spine, there is a supraspinous fossa. Below the spine, there is an infraspinous fossa. These will be important because one of the rotator cuff muscles is named the supraspinatus. It has its origin here in the supraspinous fossa. Another rotator cuff muscle is the infraspinatus. It has its origin in the infraspinous fossa. So supraspinous fossa above the spine, as its name implies, the infraspinous fossa beneath the spine, as its name implies. If we were to look at the socket itself, we see a glenoid cavity, we see the acromion, and then we see a small coracoid process, which interestingly is actually its own separate bone, which fuses to the scapula. Um, and earlier I had shown an epiphyseal line where the two are fusing, if that's of interest. So how does one distinguish between the acromion and the coracoid process? Well, the acromion is larger, but also, as I had said, the acromion is the end of the spine. You can feel that with the clavicle. The clavicle contacts the acromion, which is continuous with the spine. This knob here, the acromion, is continuous with the spine of the scapula. This coracoid process is not. And so once again, if you were confused, in a lab exam, you could cheat. You could just say, all right, the acromion must touch the acromial end of the clavicle. That's continuous with the spine. Now notice here's the other surface of the scapula, the anterior surface. Notice that there is no spine. There is a depression for a rotator cuff muscle. This is called the subscapular fossa, and the muscle known as the subscapularis is located here. So notice of the three fossa, there's a supraspinous and an infraspinous. Obviously the root spine is in the name, so you know they must be on the same side of the scapula as the spine, the posterior, while the subscapular fossa does not have the term spine in it. So then it must be on the other surface that doesn't have the spine, the anterior surface of the scapula. And then finally, some of the images that I've used and others I have here as well, just going through. Here is the pectoral girdle composed of the clavicle and the scapula here. Notice the clavicle has a sternal end and an acromial end, as we'll see in a second. Here's the coracoid process. Notice that that wasn't continuous with the spine, while the acromion is the end of the spine of the scapula. We see a supraspinous fossa and infraspinous fossa. That's that ball and socket joint where the head of the humerus articulates here. And so this is just another set of views and some labeled images of the scapula that I covered. Very often it's useful to look at the same bone from multiple views because you get slightly different landmarks being prominent. So this then is the pectoral girdle, the clavicle, and the scapula. The pectoral girdle then articulates at the scapula with the one single bone of the upper arm, the humerus. Now, before you start to identify structures on the humerus, once again, you should distinguish between left and right. If you don't know whether you're looking at the left or right humerus, then you're going to start getting some of these wrong. So once again, I need to determine which end is up, which faces superiorly or proximally now that we're talking about the limb, which end is down or distally now that we're on a limb, which is medial versus lateral, and which is anterior front or posterior back. So I see obviously there's this round ball as the head of the humerus, knowing that the shoulder is one of the two bodies ball and socket joints, then I know that that is the proximal end of the humerus, faces superiorly, because that's where the shoulder joint is, obviously. The ball wouldn't face this way because I don't have a scapula out here. My scapula is here, so that round head must face proximally and medially so that it can articulate with the glenoid cavity of the scapula. Now my only remaining problem is to distinguish which is front and which is back, which is anterior versus posterior. And at this point, just to liven up the class a little bit, I say I'm going to do a magic, trick. I tell all the class to, hold their arms like this, please, no fingers raised. And then I say, feel this big knob of your elbow, the olecranon. Okay, now extend your forearm. And I always say, oh, where did it go? It disappeared. Obviously, it didn't. So obviously, this big knob, if you don't feel it when your forearm is extended, it had to go somewhere. All right. So not only do we have this big bony knob of an olecranon, we have a fossa, an olecranon fossa, which fits it, and that's why it can disappear. Obviously, this must face posteriorly. This must face back. Because when you do this, then obviously that depression must be on the posterior side of your arm. So when you look at the humerus, one side has a prominent olecranon fossa, which could then fit that olecranon, and the other side doesn't. And once again, you can cheat in that you could, just kind of walk, all right, so the head of the humerus has to go this way, the olecranon fossa has to face posteriorly. So if you're asked, say, on a lab exam, is this bone a left or right humerus, you can often work through it by referring to your own, bones to get the answer right. Now that we know whether a humerus is left or right, let's start off at the proximal end and start to identify structures. So there is a round head of the humerus. This is the round ball which articulates in the socket, composed of the glenoid cavity, the acromion, and the coracoid process. Underneath a head, anatomically, we say that there is a neck. So just distal to the head would be the anatomical neck. The problem is that most people don't care about the anatomical neck and will then often refer to another region as the surgical neck. And the reason for that is because the head is rather wide, the anatomical neck is rather wide, the humerus narrows here at the surgical neck. And when we deal with, say, fractures of the humerus, this narrower portion is more likely to fracture than this portion. So hence, the term surgical neck, and then we could say that, the humerus has one head, but two necks, an anatomical neck and a surgical neck. Between the two, there are bumps. And once again, muscles often attach to a bump or a ridge. I'm not sure why it's not catching up with me. Come on. So muscles often attach to a bump or a ridge rather than a flat surface. So once again, I'm sorry that it was dragging behind. There's the head of the humerus, the anatomical neck, and the surgical neck. And these bumps then are important because we want to move our arms. The only way we can move our arms is if muscles then attach to arms. And so if we see bumps on the arm bones, then it's likely that muscles are attaching there. So between the anatomical neck and the surgical neck of the humerus, we have these two bumps called tubercles. One we call the greater tubercle, and notice that one can see that not only from the anterior view, where the front view, where both of these tubercles are visible, but also from the posterior view. All right, only one of the two tubercles, the greater tubercle, is visible from the posterior view. There is a smaller, lesser tubercle, and that is only visible on the anterior view. And then there's a groove between them, a groove between the tubercles, which one could call the intertubercular sulcus. And while, this is important because if you're in lab, you want to be able to identify these. When you study muscles later, you'll be learning, Three of the four rotator cuff muscles, they have their insertion on the greater tubercle. The fourth rotator cuff muscle, it has its insertion on the lesser tubercle. When I look at the chest muscle, the pectoralis major or the latissimus dorsi, they're going into this region of the intertubercular groove or sulcus. And so then these are good terms to know, not only here if you're studying for, say, a quiz on the bones, but also muscles for later. So at the proximal end of the humerus, there's a number of structures to know. As we proceed down the shaft of the humerus, we don't really see anything of note, except maybe, there's a little bit of a ridge part way down. Just a very, low ridge. You'd think, oh, but it's not that prominent, we wouldn't want to know it. But it turns out we do, not because, as a bony structure, it stands out, but because an important muscle inserts there. So because the deltoid muscle, which abducts the arm, the deltoid muscle inserts here, that's known as the deltoid tuberosity. So partway down the shaft of the humerus, we have the deltoid tuberosity. Now let's look at the distal end of the humerus. At the distal end, we have two condyles where the humerus articulates with the bones of the forearm. And we're going to give them names. Now, distinguishing between these two condyles, I'm sorry, I'll get back to that, is going to be important, and it actually gets easy once we know the forearm bones. So the two condyles where we articulate is this kind of lower, broader trochlea that's going to articulate with the forearm bone, the ulna, and this round capitulum. We can see them more on the anterior surface, all right, which makes sense because when our elbow bends, it's going, anteriorly, so we want an articular surface there. But then also notice we can see the olecranon fossa on the posterior surface. Once again, one of the ways we know which is front or back is that the knob of the elbow, the olecranon, has to fit into a space. That's the space there. So there is the olecranon fossa on the posterior side of the humerus. On the anterior side, there is a small depression, the coronoid fossa, but it's nowhere near the size of the olecranon fossa here. Given that these are condyles, we can refer to the raised portions on either side as epicondyles, and we have a medial epicondyle and a lateral epicondyle on the medial and lateral surfaces, obviously. And you can actually feel that your forearm muscles go there. So when you flex, your wrist or fingers, when you extend your wrist, you can feel that they are then attaching to the medial and lateral epicondyles. Once again, whenever we see that there are bony ridges, very often muscles are attaching there. Once again, where the humerus articulates with the forearm bones, we have a trochlea and we have a capitulum. The trochlea articulates with the ulna, the capitulum with the humerus, and this will become, there's an easy way to remember that once we study the forearm bones. So both ends of the humerus and then have a number of structures to identify. Once again, we're about to go into the bones of the forearm, but just kind of just to help us here. Students often say, all right, I know I have to identify the trochlea versus the capitulum, and if there's a piece of tape on one, and you have to identify what is this, what is this? Well, what we want to get to when we talk about the forearm is once you know that the ulna is the forearm bone on the medial side, and I'll get to that, then you remember, well, the ulna is the medial bone, and the ulna has a trochlear notch. So the trochlear notch of the ulna must articulate with the trochlea of the humerus. That must be the medial side. And if this is the head of the radius, I could remember that the head wears a cap, so that the head of the radius articulates with the capitulum of the humerus, and I could remember it that way. And so students struggle with this. How do I remember which is which? But now that you know how the humerus sits in the body, you say, oh, the trochlea, that's the medial one. And I know that because the ulna is my medial bone, and I'll talk about that in a second. And then the radius is the lateral bone. The head of the radius wears a cap. Now I can distinguish between the two condyles at the distal end of the humerus, the trochlea on the medial side, and the capitulum on the lateral side. And so some of the photos that I use in my classes are in this video, where you can see the head, the greater tubercle, the anatomical neck, the surgical neck, and then on the anterior, so posterior. So here's the head, the anatomical, so on the anterior surface, here you can see the lesser tubercle and then the groove between the two tubercles. So there are two bumps here. There's a lesser tubercle, a greater tubercle, and a groove between them. We'll see that better in an upcoming picture. That is the anterior surface. And then once again, that's important for the muscle attachment. So here you can see there are two grooves, or two bumps that we see on the anterior surface, the lesser and the greater tubercles. There was only one here, right, and on the posterior surface. So on the anterior surface, lesser tubercle, greater tubercle, and a groove between the two, once again, important for muscle attachments. There's a deltoid tuberosity partway down the shaft of the humerus. And then at the distal end, we see the olecranon fossa that can receive the olecranon of the ulna. And then we also see the condyles, which articulate with the bones of the forearm. There's the olecranon fossa there. Here's the medial and lateral epicondyles. And then once again, here's the nice round capitulum and the trochlea, the round capitulum and the trochlea. And if you ever struggled with, how do I remember which is which? Once you orient yourself on the humerus and you know that this is medial and this is lateral, the trochlear must articulate with the ulna, which has a trochlear notch, and it's the medial bone. The lateral bone, the capitulum, has a round head, and the head wears a cap. So you could, say that the head of the humerus articulates with the capitulum. And once again, you can reason a lot of this out just by, thinking about your own skeleton. And so during a quiz where your mind may be going blank and you might say, I know I studied this, but, it's just not coming to me right now. Being able to reason through this, as you sit at a station, that's important. There are two bones of the forearm, and I'm going to go through the ulna, how we can distinguish left from right. Well, once again, we have to figure out which end faces superiorly or proximally on the limb. So here you can see that that's the elbow, the olecranon. Obviously, that faces proximally. So once again, here is the olecranon. So that's the proximal end. So that's easy. And then this one other thing, I do it in class. A lot of times it's hilarious. Whereas I hold an ulna up and I say that there's, this notch, this trochlear notch. And then I tell everyone, students, put your fingers here on the posterior side. Can everyone feel that notch? Yes, everyone can feel that notch. I have a lot of students saying yes. And I say, if you can feel that notch, stop and go to the hospital. You shouldn't be feeling that notch here on the posterior side. That faces forward. And so then the point is, there's this trochlear notch. Does that face anteriorly or posteriorly? Well, you cheat, because if that faced posteriorly, you would be able to feel it. You would be able to put your finger in a notch here. You obviously can't. So this does not face backwards, or else you could feel it. That must face anteriorly. So now that we know which is the proximal end, which side faces anteriorly, then the only question is, which faces laterally. And once again, here you cheat. And this would actually help you in AMP2 as well. There are two bones of the forearm, and you have to know which is medial and which is lateral. And once again, in anatomical position, we stand like this. And it is so easy to cheat because the ulna is very superficial. You can obviously feel it at the elbow. And here you can drag your finger along the ulna and you never lose contact with it. Just pause for a second. So we can feel it all the way down our arm. So if you ever forget that the ulna is the medial bone and the radius is the lateral bone, you cheat. You brought two ulnas with you to class. Use them. All right. I mean, no sense getting the wrong answer just because you didn't touch your own arm. So touch your ulna, and then you can feel it all the way down your arm, and you can establish that that then is the medial bone. If the ulna is the medial bone, then the radius must be the lateral bone. And as you know, we'll stress a couple of times, the head of the radius spins in a notch. Now you can actually feel that if you were to hold your arm like this, come in from the lateral side, and then pretend that you're waving goodbye. You can actually feel the round head of the radius spinning. And the ulna has a notch for that to happen, a radial notch. So not only is there this trochlear notch that faces forward, once again, you'd notice if it was facing backwards. Here's this radial notch where the head of the radius can spin. You can actually feel the head of the radius spinning there. If the radius is the lateral bone, then obviously the radial notch has to face laterally in order for that to work. And so the ulna, it's easy to distinguish between left or right because this big knob is the elbow. That's the proximal end. This doesn't face posteriorly. You could feel it if it did, so that faces anteriorly. And if the radius is the lateral bone, then that radial notch where it spins then must face laterally. On the radius, we refer to a head, a neck, and it's the head of the radius which articulates not only in that that radial notch, but remember that the head of the radius articulates with the capitulum. So you could say a head wears a cap. And here's the neck where it narrows. And here we can see the radial tuberosity where the biceps brachii inserts. Once again, whenever you see a bump on a bone, very often you think, oh, I want to remember the name of that bump because I'll bet you a muscle attaches there. And in this case, it's the biceps brachii, which allows us to flex our forearm. And so those are the structures at the proximal end of the forearm bones. Now, this material keeps coming up, especially because we'll be talking about joints, articulations, and different types of movements. But when we pronate and supinate our forearm, which then causes to pronate and supinate our hand, then the head of the radius is rotating in this pivot joint here with that radial notch there. So when we talk about the movements of the forearm, we're talking about pronation and supination. We'll get back to then that spinning of the head of the radius in that radial notch. Now, once again, we'll be talking about joints and articulations more in just a little bit, and then in another chapter. The ulna is certainly very prominent at the elbow end. Towards the wrist end, it takes on a more of a supporting role. And it is the radius then which articulates with the carpal bones to form the wrist joint. So the wrist joint primarily is a joint between three bones, the radius, and then two carpal bones, the scaphoid and the lunate. At the distal end, each of these bones, the radius and the ulna, they have a little bony protrusion known as the styloid process. Once again, there are a couple of bones which have a styloid process because anatomists were reminded of stylus pens that they could dip into an inkwell in order to write. As we proceed along the arm, and I'll have pictures of the radius and ulna in just a bit, there are then 8 small bones in what's called the carpus or wrist. So here we see the carpus, and there are 8 bones, and it is helpful to remember that there are 2 rows of 4. So here's 1, 2, 3, 4 bones on the row which faces the bones of the forearm, and then there will be 1, 2, 3, 4 on the row that faces the fingers. So there is a proximal row of 4 bones, and there is a distal row of 4 bones. Now, I'll go through these obviously, but I often tell my students that of these 8 bones, there's 3 that I really want them to know, that if I was going to ask them to identify some, that 3 of these 8 would be more likely to be named. The 2 of the 3 that I would want them to know are this first one, the scaphoid, and this one, the lunate, because it is these bones of the carpus which articulate with the radius at the wrist joint. So the wrist joint is between the radius, the scaphoid, and the lunate. If you were to break a wrist bone in a wrist fracture, most of the time the scaphoid is the only bone of these 8 which would break. So that's important to know. Then we have a triquetrum and a pisiform. The pisiform is easy because all of these other bones you can observe on both the anterior and the posterior side of the carpus, except for the pisiform. And if you feel what's sometimes called the heel of the hand, right here you just feel like a little bony knob, that's the pisiform, and that is only evident on the anterior surface. Working then on the distal row of 4 bones, the first one we see is the trapezium, and I would also then heavily emphasize that bone with the idea that that's one that's more likely to be asked. And the reason is that when I'm teaching in class, I say, students, look at this, see what I'm doing, huh? And no one is impressed, and that's fine. I say, well, you shouldn't be impressed, because what can a crocodile do with its fingers? That. What can a frog do with its fingers? That. Everybody who has fingers pretty much can do that. But look at that. This is special. This opposable thumb, all right, which gives me this dexterous hand for climbing, for tool use. That's what we find impressive. The movements of the thumb. The movements of the fingers are really kind of the generalized movements that anyone with fingers have. And the reason that we have opposable thumbs and a highly dexterous thumb is because of the joint between the trapezium and the metacarpal of the thumb. It's what's called a saddle joint, the only saddle joint in the human body. And so this trapezium, it is part of a unique joint in the human body, which gives us very dexterous thumbs, which is very important for tool use and manual dexterity, etc. So the trapezium, so if we were starting on the lateral side, the thumb side, the trapezium in the distal row, that's important. And then that's followed by the trapezoid, the capitate, and the hamate bones. And so the bones of the carpus, there are 8 of them, and there are 2 rows of 4 bones. And so, you would be, good to think of them as a proximal row, a distal row, but also to remember the scaphoid, the lunate, and the trapezium before the other ones. Articulating with the carpal bones are then metacarpal bones. We number them, and we start with the thumb side, so that way if someone has a fracture in one, you could say it's a metacarpal 1 or metacarpal 2, etc. So the metacarpal of the thumb is free, but the metacarpals of the fingers, this is what makes up much of what would be called the palm of your hand. So when you make a fist, you're looking at the metacarpals here. We then have phalanges composing the digits. There are proximal phalanges, there are middle phalanges, and then there are the distal phalanges. So while the fingers have proximal, middle, and distal phalanges, the thumb only has proximal and distal, no middle phalanx. And so therefore, we have 14 phalanges in total, because each of the four fingers has 3, and then the thumb has just 2. And so then I end, the arm here with another video, where I just, on this animated skeleton, look at the ulna, which has the olecranon that we feel in the elbow, this trochlear notch, and then the radial notch, which has to face laterally because that's where the radius is. The ulna is the medial bone. If you were in anatomical position, you could trace it all the way down. The radius is on the lateral side, and the head of the radius would then spin in that radial notch. It has that nice round head to do that. There's the radial tuberosity where the biceps attach the neck. The radius is the bone which forms the wrist joint with the scaphoid and the lunate. The ulna has more of a supporting role at the wrist. So the wrist joint, the radius articulates with the scaphoid and the lunate, these 3 bones. Notice that there are these 8 carpal bones with 2 proximal rows, a proximal row of 4 bones and a distal row of 4 bones. The trapezium helps to give us that opposable thumb because of the saddle joint. So that's important, as are the scaphoid and the lunate, which are composing the wrist joint. Scaphoid and lunate, notice from this view, you don't see the pisiform. That would only be evident on the anterior surface. Articulating with the carpals, we then have metacarpals on the thumb, and then here are the metacarpals here of the hand. And then articulating with the metacarpals, we then have proximal phalanges, middle phalanges, and then distal phalanges on the fingers. And on the thumb, we have a proximal phalanx and a distal phalanx. So we take our take our skeleton, and the first thing that we do is we divide it into an axial and an appendicular portion. The appendicular portion, then we split into the bones of the arm and the pectoral girdle, which supports them. One last thing on the pectoral girdle. Our pectoral girdle and our arm is a little reduced because it's not weight bearing. Right, so a lot of animals walk on all fours, and so therefore the arms and the shoulders have to be a bit stronger. Whereas because we're upright, we don't have to bear as much weight on our arms and shoulders, so it's a little smaller than what we see in other organisms. One thing is, while some animals lose the clavicle or have reduced the clavicle, primates often hang. And so that we have maintained a prominent clavicle because in hanging, it is innate. The next video will then go through the pelvic girdle and the leg.